grand rounds as follows. Because we're recording this here, that's good. Um, the there's a passing of the baton in these rounds, and that I've been really the medical director since 2013 when we started. And we're going to have two new co-directors. They're with us. Dr. Mike Katsaris is with us, who's a professor of medicine, rheumatology, and a great teacher of med students. I've worked with him, and he's a true teacher. And then Dr. Greg Pescia, who is also a professor of medicine at Western University. And he is a specialist, particularly in terms of innovations in medicine. And there's no better innovation than telemedicine, which we're trying to do with these sessions. So we've got really, I call it high-powered co-counsels coming, use this sort of Roman type analogy, who are going to be replacing me in terms of these grand rounds. And we'll do some rotating in terms of master of ceremonies, exactly how to do them. But there'll be a transition in terms of the older guard. Remember, I'm 81, and that's an older guard. I'd call that old. The old guard's going to be becoming a consultant. I'll be available. I'll do all I can to help Greg and Mike in terms of their direction. And I predict that the level of world penetration and getting telemedicine effective in the world is going to get much better next year. I think we're at a point where, you work hard to get to first base, then it's easier to get to second, third, and really get home. So I think we're on the base path now. We've made it to first. And once you get on base, you can run a lot better. So really the mentoring, the teaching, the directorship will be with our new two co-directors, Greg and Mike. And it's my pleasure to have them really take over this position. And I'll be meeting with them at 9:30 today. We're going to talk about the transition in terms of doing that very, very well. Um, Greg and Mike, would you want to give a comment before we start off? Anything you'd like to say?
Yeah, I'll start. Thank you for the kind introduction and the opportunity to serve in this amazing adventure and enterprise that you've been able to build. And like you say, we're on first base together. I think we've got a good lead, and all it takes is a little support from the batters that come on board that are in the what do you call it, the on deck circle,
There we
and,
are.
uh, and to move all the runners forward. And I agree. I think we've got great opportunities building upon what you've all been able to do together with this incredible team at Goski. So thank you for the opportunity. And with that, I'll cede the rest of my time to my colleague, Dr. Katsaros.
Yeah, it's likewise. I mean, I think this is a wonderful opportunity, and we just want to build on the legacy that you created here, Dr. Good, and to continue on and enhance the educational experience to this community. So we look forward to that.
And I couldn't be replaced by two better individuals, and I know we're going to go in a better direction. And I'll be there as much as I can in terms of consultant, um, and looking forward to the partnership as we try to make world telemedicine better, actually trying to improve world health with telemedicine. That's what we're trying to do. And when the young ladies like Alexandra, who is our associate director, and two others, Lauren and Katie, they'll be arranging grand rounds, and uh, they're the amazing abilities of pre-med students. They're such a resource. They're all pre-med, and their intellect and their organizational ability, particularly with Farine. Farine, are you with us? Farine is taking us to a new Google level of competence, which we didn't have
I'm
previously.
here. Good morning,
But
everyone.
Farine, I'm so appreciative of you. You're going to med school at UC Davis, and you have been a light in the tunnel for this group. And I'm going to look forward to doing consulting work with you, and we'll carry this on. But you have brought us to really a new position, and thank you, Farine.
Thank you, Dr. Good.
Okay. Well, with that, let me turn things over to Dr. John Strasswimmer, and he's what we want. He's a dedicated teacher Rotarian who really has a global aspect, who's very involved in Africa. What more could you ask? in terms of a teacher in this session. So Alexandra, I'll let you turn it over to John, okay?
Yeah, thank you everybody for joining. Super happy to have you all here. Thank you, Dr. Strasswimmer, for creating an incredible presentation today. Just as a reminder, these grand rounds are CME accredited, and if you or anyone you know in medicine is interested in presenting, these are a teaching grand rounds. So thank you all for coming. And Dr. Strasswimmer, if you would like to share your screen, it's all you.
Thank you very much for the opportunity to share some information today with, I hope will help those clinicians who are dealing with COVID. Yesterday, our hospital chief medical officer gave an outstanding update on coronavirus here in the United States and South Florida, including therapeutics and some of the challenges. And I believe the number he cited was the total number of publications now are near 100,000. A tremendously large number of papers that have come out related to coronavirus and COVID. So that's too much for anybody to go through. Dermatology, oftentimes when we give presentations, people's eyes glaze over because it's nothing but a bunch of red scaly rashes. I'm hoping today to share with you some concrete information which will improve your skills to be able to serve patients better. Pardon 1 second. Where is my? I'm trying to see. Are you seeing the? Are you seeing yet?
Yes.
Oh no. Yeah, we got him.
I apologize about that. Okay, thank you very much. I was invited to participate a little bit over a year ago to discuss the rashes of COVID when we were in full crisis through my Rotary Club, which is the Rotary E Club of the Southwest USA. And our club has been, I believe, supporters through the Rotary Fellowship of Physicians. And I would encourage all of you to consider Rotary if you're interested in some sort of global network of people to help. And I'm going to, wait a second. And okay, there we go. The disclosures is I also do clinical trials research, and I'm a paid speaker for 3 companies, Genentech, Roche, Regeneron, and Sanofi. I do not believe they're related, although Regeneron does have a product to treat patients with COVID infection, but I don't use it, and I'm not going to discuss it today. Okay, the goals for today, at the end of this discussion, the participants really should understand that 3 rashes, if you can learn 3 rashes that will make you think COVID, you've accomplished a great deal, okay? I'm also going to review the other findings of COVID-19 disease, and then I would like the participants to understand that skin examination in a patient who's potentially at risk for coronavirus exposure or COVID-19 disease should be part of that as well. Okay, here's the take home. After the next minute and a half, you can all log off. These are the answers. This is all you need to know. Right here. So number 1, skin eruptions in patients with COVID-19 disease are very common. And 17% of the time in patients who develop a rash, it precedes their other symptoms. So before feeling unwell, before a cough, fever, swollen, anything, these rashes show up first. And in fact, in 20% of patients, it's the only clinical finding. And I'm going to share some of the data around that. The only thing they'll show up with is a rash, and these are COVID positive 19 patients who are transmitting the virus and are at potential of becoming sick, but clinically, some of them will only manifest with a rash as well. There are some which are really characteristic of this. There's sort of 5 main categories that we'll go through, but I'm really going to try to bring that down to 3. And then 2 questions really will help us at the patients. Number 1, you ask them, do you have a rash? Did it appear? And is it, in particular, is there a rash on your body or is there a rash on your hands and feet? And if those 2 questions are a very efficient way to do screening, when you get a phone call or other communication from somebody who reports that my mother tested positive or my cousin and I'm worried about COVID, asking those 2 questions, do you have a rash? Is it a rash on your body, which is raised, itchy, red, or scaly? Or do you have a new rash on your hands or your feet? All of this work is done to my hero and Dr. Albert Schweitzer, who was the first doctor to go practice in the developing world. And his goal was to address the needs of local people rather than what was being done at the time, which was to go and serve the needs of the colonial powers, which is to keep the local people as laborers healthy. He went completely separate from that. A lot of people wanted to follow him in his footsteps, and he really encouraged us to go ahead and find our own ways. And at that time when he was in practice, my field, dermatology, we were this sexually transmitted disease specialty. It was really dermatology, was primarily syphilology, at least in Europe and the United States. And that was because syphilis is the great imitator. Kind of like COVID, it's kind of hard to know who gets it, why gets it. It shows up in a lot of different ways, and it really became our subspecialty in medicine. So much so that the actual founder of my medical practice here in Florida, who just retired at age 93, his diploma from Harvard, before I went through, my diploma says dermatology and cutaneous surgery. His diploma says dermatology and syphilology. So our specialty has been one which has really been designed to kind of identify unusual skin findings to help figure out, is there something going internally? And two, in the United States, who advanced this, were somebody to identify that skin has its own diseases and that it can be a window onto the body. So for example, this patient right here with what looks like herpes, this could be herpes or it could be something else. And that's the background of dermatology today relevant for this. So our goal is going to understand that patients can present with COVID-19 with little or no systemic involvement, including pulmonary involvement. You should consider questioning, either incorporating skin exam or asking about skin exams, and just 3 rashes, please. Okay. This is a case from a year ago. When we were up to our ears in COVID down here. This is a patient otherwise healthy, lives with a crowded family, and she had hives. And the question was, should that patient be addressed for COVID? At the time, what we could rely on was this one paper, which was a Herculean task done in the middle of the crisis in Europe with hospitalized patients in Spain. And dermatologists basically scoured the wards throughout the country. And in a 2 or 3 week period, the entire country dermatology force was mobilized to just walk into the hospital, find the patients who are hospitalized for COVID-19, and take pictures of their skin findings. Those were sent in a blinded fashion to dermatologists who got thousands of photos and tried to make some sense of them and say, is there anything that's a recurring theme? And they did come up with some recurring themes as rashes they were seeing. But more importantly, is a recent project done in England by the British Association of Dermatologists, which was just recently published in April this year. And that's what prompted me to want to give this talk today, which is that we were able now to find that some of those rashes and eruptions that were described a year ago in the Spanish group, those were for hospitalized, very sick patients. The question is, for patients who are in the community, is the identification of these rashes, is it important or is it not important? And so this wonderful study, which was published in the British Journal of Dermatology, answers that question. And I'll describe briefly the way they did their study. The United Kingdom instituted an online app back in the spring, early summer last year, which asked just healthy people to download it and every day answer questionnaires related to COVID. So are you healthy today? Yes, yes, yes. And then they said, did you have a COVID test? Yes or no? And when people end up answering yes, that they had a COVID test, maybe because they're exposed, maybe because they were not feeling well, maybe because somebody close relative or close contact had tested, so they went in for an asymptomatic testing request. They were then able to retrospectively look at the previous day self-reporting that patients had done and discovered that a fair number of them had reported rashes before they got tested for COVID-19. So that is part of the incredible value of this as well. This is a recent case in my own hospital. This is a patient who was admitted to the intensive care unit here in Florida in February 2021. 22-year-old woman, absolutely healthy, no background at all. She presented to the emergency room with this horrible rash on the lips, and I'll show you some more of her skin. She had pancytopenia. She also had elevated liver function tests, and she developed acute swelling around the throat, required emergency intubation. And this, she had never had any lung findings, anything other than the swelling preceded by a little bit of arthralgias, a little bit of lower back pain. As part of her workup, she had a bone marrow biopsy, which showed she had the unusual autoimmune finding of amperopoiesis, which is also called hemophagocytosis, which is an autoimmune condition whereby the macrophages in the bone marrow go crazy and they start eating the developing red blood cells and platelets, causing a pancytopenia. And this finding, this hematologic finding, can be found in some autoimmune conditions and in some lymphomas, and rarely associated with some infectious conditions, such as herpes simplex and other viral conditions. It had never been reported before and is still not yet reported. We haven't published it yet with COVID-19. Again, this is the interesting finding. You can see right here, this is a bone marrow smear. This is a macrophage right here. The little black arrows are platelets, which have been engulfed by this macrophage. The red arrow indicates a red blood cell, which has been engulfed by this macrophage, contributing to her pancytopenia. And she is actually now on chemotherapy to treat these crazy macrophages so they stop eating her blood cells. On admission, she had a negative COVID by PCR, negative COVID antigen tests. Those tests, the sensitivity and specificity of those tests are still terrible. But 1 week after admission, I was able to see her bedside, and she had some characteristic findings which had been described by the Spanish literature. These kind of petechiae, acral rash on the elbows. She had the early what we call COVID toes, which are basically the white blanching. We're going to look through in just a little bit right there. A little bit more detail on her heel as well. And I requested additional serology testing, and indeed, she tested positive by IgM for SARS coronavirus 2. So she has SARS, which has triggered this condition. So the question is, a woman like this, had they called the dermatologist early in her condition for unusual skin findings, could we have maybe got her some earlier treatment, which might have maybe aborted some of the later problems that she had right here. So these are some of the rashes. Again, this is where your eyes are going to glaze over, the descriptions of the rashes that have been associated with this, but I'm going to really try to narrow it down to 3, and then we'll add on the other ones as well, okay? So these are the 3 skin rashes right here, which every doctor and allied health professional who treats patients can be familiar with. The first one is chilblains. Chilblains means little purple, usually sore spots on the fingers and toes, often associated with cold. And it's an inflammatory response to a variety of things, seen in lupus, for example, most commonly. Pityriasis rosea is a very common rash that occurs in the spring and the fall. It's associated with a variety of upper respiratory conditions that causes characteristic rash. And when I show you pictures, you're all going to remember that. And finally, measles. And if any of you have ever given a patient a course of penicillin and they get a maculopapular rash, that maculopapular rash is actually called a morbilliform or measles-like eruption. And we call that a morbilliform eruption that can be seen, for example, as a response to penicillin, but it can also be seen with COVID. So this is the first finding I expect all of you to please try to learn. This is chilblains. This is regular chilblains, not necessarily associated with COVID, these pictures right here. But usually red-purple findings on the fingers and toes, usually very painful. And the descriptions are they can be itchy or tender red-purple papules as a reaction to the cold. It's also known as pernio. And so sometimes we call it lupus pernio, but chilblains is the more common type of finding right here. And it's a vasculitis. There's some inflammation happening in those tiny terminal blood vessels that are causing them to restrict blood flow. And then when you add on top of that a little bit of cold exposure, it causes more constriction. And we see these commonly in lupus and lupus-related diseases. That's why we often call it lupus pernio. Its other name is chilblains, and you can find this in COVID-19 disease. And again, little purple, red, painful, itchy, usually on the fingers and toes. Okay. The second one is the morbilliform eruption. And it's called morbilliform because it originally was described in measles. And this is the so-called maculopapular rash. And this exact same rash can happen in patients who've been given penicillin and they get a so-called penicillin drug rash. This is it. This is the so-called maculopapular rash. We dermatologists hate that term. We perform morbilliform eruption. It usually starts from the head down, usually in the trunk, and goes out to the arms and the legs. It's called maculopapular because there are macules, meaning flat spots. If you put your finger across them, you'll see red, but you won't feel anything. And papules, meaning red spots. If you put your fingers across them, you'll feel bumps, and they extend out to the sides. So just if you think of a patient you've ever treated with an antibiotic and they got a drug rash, it was probably a morbilliform eruption. And that morbilliform eruption, whose name derives from the term for measles, is commonly seen as well in COVID infections. So again, this is a morbilliform eruption, and these patients were just walking down the streets, quite frankly. You wouldn't know if this is measles or this is a penicillin rash. Or in this year 2021, you would also consider COVID with these patients right here. The third rash, and then we're done. That's it. Once you learn these three rashes, you're kind of home, okay, is pityriasis rosea. This is commonly called the Christmas tree rash. People start with one scaly patch, which is shown in the upper slide here. That little scaly oval patch usually starts in the spring or the fall, somewhere on the trunk, could be in the front, could be in the back, characteristically there. And then it's followed by a bunch of usually light pink, slightly scaly spots that appear, and they line up in little lines. If you stand back and look at the back of the patient, you could convince yourself that those lines fall in a little bit of a Christmas tree pattern in this area right here. And this is known to be associated with a whole slew of common upper respiratory infections. So adenovirus can cause this, some herpes viruses, herpes virus 6 and 7. But typically, we see it in the Northern Hemisphere in the spring and fall, associated with minor upper respiratory infections. Quite frankly, oftentimes there is no associated upper respiratory infection, and this is the only finding in these patients. So not surprising that COVID can do this too. So three rashes, chilblains, morbilliform eruption, and pityriasis rosea. So this again is pityriasis rosea. This is a typical showing. You can convince yourself that these little red scaly bumps are actually falling in a Christmas tree type pattern on the trunk and the back of the patient. They get red with a little bit of scale on top of them. Three rashes, that's all you have to learn. So going a year ago, I had a patient who called again. She had that.
Can I ask something before you go very further? Otherwise, I may forget.
Thank you.
So the piliform rosea and the other, the chilblain, does it have the same texture, like when you try to?
Yeah. So the question is the texture when you feel these rashes. First of all, that's an incredibly important question you just asked. With dermatology rashes, it's really important for us to distinguish whether or not you can feel them or not feel them. If you cannot feel them, they're called macules, and if you can feel them, they're called papules. So pityriasis rosea, all of these will be papules. So you'll feel every one of these bumps you put on this, you'll feel them. For the morbilliform, the measles-like eruption, you'll have a mixture of macules that are not raised and papules that are raised. And for chilblains, they will be raised. They really should be raised because it's a swelling of the blood vessels and they're really going to push up a little bit. You might not be able to appreciate it that much, but that's that. That distinguishes us from something which is just simply a problem of platelets. For example, somebody with low platelets, they're going to have little petechiae, little microscopic bruises, maybe on the fingers or on the lower legs, and those you will not feel. Usually you will not feel. So if you can feel it, usually if you can feel the bumps, that implies that there's an inflammatory process going on. And that inflammatory process could be secondary to an autoimmune conditioning, which is leaving some little microscopic particles to accumulate in the terminal blood vessels, triggering inflammation, in contrast to another common thing, which is non-inflammatory, which would be, for example, a loss of platelets and just getting little teeny tiny petechial bleeding and blood clots, which are non-inflammatory and therefore not raised. Is that helpful?
Yeah, very helpful. Thank you so much for the explanation.
And I appreciate you so much for asking me to pause and go through this. I would love to make this as interactive as possible. And I apologize, I don't have a lot of pictures of dark-skinned patients. However, prior to begin the session, I explained I have colleagues who regularly have partnerships in Botswana, in Uganda, in Ethiopia, who do have slide decks ready to go for dermatology teaching, which includes people with darker skin complexions. And we're trying to address that problem here in America as well. It's a systemic problem. Okay, so this is a patient who otherwise healthy, lived in a crowded room. She did not have one of those 3 rashes that you have to learn, but you all know hives. Everybody knows hives. So she called me, she said she had hives. So the question, should she have been referred for COVID testing? And I'll tell you the answer at the end, okay? Oh, okay, so this is the first finding right here. Of the 3 rashes we're gonna learn, this is, we're calling this pseudo chilblains right here. So these are, again, these are little red, painful, itchy papules on the toes and the fingers, okay? And as I reviewed, they can be associated with lupus or other inflammatory conditions, which is why we sometimes call chilblains lupus perineo, or just perineo as well. These are pictures of patients with actual COVID-19 disease. And these patients right here have, again, you can see these kind of red, itchy, painful bumps on the fingers and toes. They can actually might even blister a little bit as well. You see that on the fingers and toes. And the patients who are hospitalized, the actual cold part of them might be the heels, because if they're laying recumbent on the thing, the cold part of them might be the heels. So we can also see these on the heels of patients. Or if they've been walking, the combination of inflammation plus the trauma of walking might trigger these as well. So when we talk about COVID toes, which has been in the press a lot, it also means COVID heels as well. You can see these pictures right here. These are all patients with COVID. And these are the same idea, the little pink, itchy, or painful spots on the fingers or toes, but they can be on the hands and they can be on the heels as well. Hands and the heels as well. And on the fingers. These are all COVID patients right now. This right now, so that was the first rash that we learned right here. Okay, we learned COVID. So we learned perineo. You can cross that off. Now I'm giving you a bonus. Okay, I told you only had to learn 3 rashes, but I'm going to give you a bonus. The bonus is a vesicular eruption. Vesicular eruption means that the patient at one time or another had little tiny bubbles on the skin, like chickenpox. The problem is with a lot of vesicular eruptions, the patients often scratch them away before you get a chance to actually see any of the little bubbles. So if you look at these pictures right here, these are, you don't see any bubbles, but you do see erosions, little spots of skin that are missing, and they could have been picked off, or it could have been because a bubble has burst. And there are not a lot of things in dermatology that cause vesicles on the skin. One of them is chickenpox, another one is coronavirus. And of course, historically, there have been pox viruses and things like other pox viruses that do this as well. But this has been seen all over. And again, you can appreciate these are vesicles. You can see they've kind of popped a little bit, but in these cases on the hands, the patients are showing up with vesicles. Very unusual for us in dermatology to see people just show up with vesicles for any other reason. You could consider hand, foot, mouth disease, which is also caused by a virus. It's caused by Coxsackie virus. So it's not surprising that coronavirus, with a variety of clinical manifestations, it can also manifest with the way other viral infections in the skin show. So this is the bonus, okay? You didn't have to learn this one, but this is just for bonus today. Vesicular eruptions on patients, okay? Common finding, just a weird vesicular eruption. You might make you think of chickenpox, but if you're thinking of that far, you really should consider COVID testing as well. Okay. And these patients right here, these were hospitalized patients, and they've had some which are a little more purpuric. And quite frankly, that might be because maybe the virus has wreaked more havoc on their hematologic system, and they're bleeding a little bit into these lesions as well. But again, vesicular eruptions on the hands, very hard to find them in any other condition. And on the feet. Okay. So we've learned the one rash I'd ask you to learn today, which is the perineo, also called the chilblains on the finger. And I threw in a bonus. The bonus was vesicular eruptions. I'm now going to throw in another bonus. You don't have to learn this one because you already know this one. You treat patients. Patients have hives. Hives are very, very common. And if you look at this patient right here, you can see that the dermatologist, when he or she went into the hospital, drew circles around the hives. in this area. Now, the question for you is, why did they draw circles around these around what they thought might be hives or could be cellulitis or something like that? So I'll let you answer these questions. Is it because the doctor wanted to come back the next day because they're concerned these might enlarge and they wanted to track them? Or the doctor was aware that coming the next day, they might forget where these red spots were and would want to see if they're still present. Third choice was because the doctor thought this is something which might end up in a big blister, so I want to keep my eye on it. And the fourth might be because, well, this looks like it's kind of making a chain, and I'd like to see if that chain kind of continues. So I'd love to hear anybody from the audience who, with any one of these questions, A, B, C, or D, as to why the dermatologist, when he or she went in and saw the patient, drew circles around these lesions.
This is Mark Berenson. I'm on the phone here. I think the answer is all of the above.
Okay. Yeah, so exactly. So actually all of the above are perfectly good reasons as to why we draw on lesions. And I'll explain to a little, let's see if the next slide has the answers. Okay, so the answer is, number one, they might enlarge. So if we were working about cellulitis, this is a very helpful thing for cellulitis infections in the skin, right? You draw the border and you come back the next day and see if it's spreading beyond that, then you've got active cellulitis. The second, which is actually the answer for this patient right here, is because when you come back the next day, you might see these are no longer present in this specific area, but are present somewhere else on the body. And that's the definition of urticaria or hives. So hives means, or urticaria, same term, means that you have a red swollen spot, which is in one location one day, but within 24 hours, it will be gone from that location, but can certainly appear somebody else. And that process can go on for weeks, months, or even years. But by definition, a single spot must be gone within 24 hours, or it is not urticaria. It's something else, okay? So the first question is why we circle things. Number one, if it's cellulitis, we'd look to see if it's enlarging beyond the boundaries. The second, because we might not see it the next day. And if it's gone, we can say, okay, it looks like that what you had some urticaria there, some hives. Okay, so now we know what we're dealing with here. The third is that this might blister. Maybe the patient had some sort of arthropod assault, had some sort of bug bites with a toxin, and we might be wondering, we want to see if it's going to start blistering up. It might be getting worse. Or forming an enlarging chain, that might make us think about a deeper infection, such as a fungal infection, such as sporotrix infection, which is called a sporotrichoid infection, although staph can do this as well, whereby in cellulitis, the infection spreads in the high level of the skin within the fat. And so it's kind of an even spread of color. And then sporotrichoid type of spreads of skin infections, they're spreading deeper down in the lymphatics. So they'll skip areas. So you see a little red spot that pops up, and then 2 days later, you'll have an additional one that's spreading more proximally in the patient's body. So you're absolutely right. All of the above are correct reasons to draw on this. In this case, though, the reason we draw on this patient is because this patient had urticaria, and coming the next day, it would be gone. And you can actually see here, these are urticarial lesions. You all know what this is. Again, we're just on the bonuses here. You know this. You don't have to learn this one. This is hives. You can see the doctor drew the little squiggly patterns to come back the next day to see if it's still present, to form this as well. And so that's what we did. So urticaria, you see new onset urticaria in patients, think COVID. Most of the time, urticaria does not have a cause. We do not do workups for urticaria in patients unless it's gone more than a certain amount of time. We say just take some antihistamines and come back later. It's a waste of time to work them up when they're in acute urticaria. And that can be a talk for another day as well, okay? But urticaria, so again, this is a bonus. You didn't have to learn any new rashes that you only have to learn the 3 rashes I told you about. The chilblains, the pityriasis rosea, and the morbilliform eruption. Those you have to learn today, but you already know a vesicular eruption and you already know urticaria. Okay, so this is urticaria. You see urticaria? Think COVID. Okay. We have this wonderful term in dermatology that really only dermatologists use, but we call this grouping of rashes papulosquamous. Papule means you run your finger across the bump and you feel it. That's a papule. Squamous means it has scale. So of the three rashes I'm asking you to learn today, the morbilliform eruption, that is macules and papules, and those can be associated with scale, so that we consider to be a papulosquamous eruption. Another papulosquamous eruption is one we're learning today, which is pityriasis rosea, and that's the one that shows up in the Christmas tree type pattern as well. Okay. In the family of papulosquamous rashes, we also include psoriasis, because psoriasis is basically big papules with fixed scale, but psoriasis has not been described as a new finding of COVID. New onset psoriasis, incidentally, has been described as a finding in patients with undiagnosed HIV disease. And here in my practice in Florida, we made that diagnosis in one patient 3 years ago. But that's talk for another day. Okay. So again, this is the second rash that we're learning today, pityriasis rosea. So typically starts in the upper right-hand corner here. This is the herald patch, meaning a rash is about to start. It's a big oval patch, maybe 2 centimeters across, usually on the back or the chest. And then a few days later, they'll get this characteristic eruption, which occurs of papules that are raised with a little bit of scale on them. You can see the close-up, the scale is just kind of a little dusty on the top. These eruptions, this is pityriasis rosea. And then these are pityriasis rosea in COVID patients. And again, you can see how it's falling into that Christmas tree-like pattern, which is actually the relaxed skin folds of the trunk with a little bit of scale. Pityriasis rosea finding. This one was labeled as a pityriasis rosea finding. However, if you told me you thought this was more morbilliform, I would give you credit for that as well, as long as you're looking for COVID. Okay. Again, you can see on the sides here, this is falling into a little bit of a Christmas tree pattern as well. So this is the second rash for COVID that you're learning today, which is the pityriasis type formation, falling into little Christmas tree things as well. The third one today is the morbilliform eruption, commonly called by doctors maculopapular drug rash. It's the exact same rash. It was originally identified and associated with measles. Measles, however, is different because it's associated with some findings inside the mouth, the Koplik spots, and the bright red lips usually go with measles, whereas a typical maculopapular rash, which again is a term we hate, we love morbilliform eruption in dermatology. The morbilliform eruption that you'll see in COVID is characteristically not necessarily going to involve the mouth, but it will have these macules and papules primarily on the trunk extending to the extremities, again, looking just like a drug rash. If you've given somebody penicillin and they had a rash, it probably was a rash like this, and this is what happens in COVID. So these are COVID patients. You can see the macules and papules, in contrast to the pityriasis rosea, where nearly all of the lesions will be papules and raised. This will be a mixture of macules and papules. That's why people call this the terrible term, the maculopapular drug rash. In this case, it's a morbilliform eruption associated with COVID disease. Again, morbilliform eruption in COVID, macules and papules starting on the trunk, spreading out. Macules and papules on the trunk, spreading out. Macules and papules spreading out. Okay. So if you've now learned the three rashes that I've asked you to learn today, which is the chilblains, which includes chilblains, includes the morbilliform eruption of pityriasis rosea, you've learned enough for today. You can turn off your minds. We gave you a bonus, which was urticaria, which you already know. We gave you another bonus, which is vesicular eruption, which you've seen and is not very common. That should trigger that. This is just another bonus. Learn this one if you want. But we've seen also in some patients with COVID, they're just getting what we call a follicular pattern, meaning you could look at this and convince yourself that each one of these little spots is arising around a hair follicle. So a folliculitis. Okay, just kind of a weird rash. You could convince yourself that it's around follicles. And then these are the last few presentations right here. This is basically the bigger, scarier picture. This is erythema multiforme. Now this could be from a drug. This could be associated with herpes. But just like erythema multiforme, which can be a very serious skin rash, erythema multiforme can be associated secondary to medications or secondary, most commonly, to herpes infections on the lips, which can trigger this weird autoimmune condition. We now know that coronavirus can do that as well. So again, if you see somebody with something and you're thinking erythema multiforme or Stephen Johnson, think coronavirus as well. And these are more patients. This is erythema multiforme. Again, this is the bonus. You don't have to learn this today, just learn those 3 rashes. But if you want to learn something more, you see erythema multiforme, think COVID. And with these are the so-called target lesions they get, which are white, which are a little red rim, a white donut, and then a pink center. These are target regions a little bit. And these are usually secondary to some sort of insult. It could be a medication. It could be a little bit of herpes infection on the lips. You might not even see the herpes outbreak on the lips, or even mycoplasma infections can cause these as well, respiratory infections of the lungs. So again, it's not surprising that the great imitator of COVID-19 can also cause erythema multiforme type eruptions in patients as well. Again, this is more erythema multiforme. This patient might come in the hospital, somebody might say, oh my God, this patient has been on Lasix, they've got a drug rash, or they have erythema multiforme, maybe because of herpes simplex. You should also think of COVID-19 as well with these patients. And again, you can see the target lesions, these little circles, which have a distinct pink outside, then a little white inner rim, and then a red dot in the middle. These are target lesions of erythema multiforme on these patients as well. Okay, now you're all welcome to close your eyes and ignore this part if you like. This is really esoteric. We dermatologists love rashes that occur in unusual places. When we find rashes, it's basically the type of bumps. We describe those, then we talk about the distribution. And putting those 2 together, that gets our unusual diagnosis. So let's talk about knees and elbows. Think about when the last time was you saw a patient who came in with a rash only on the knees and elbows. It's very uncommon. It's very uncommon. Psoriasis does that, but psoriasis has been around in a patient for years. They'll tell you, oh, I've had this for a while. I've tried steroid creams. But to have just kind of these red dots on the knees and elbows is very unusual. This is actually another form of vasculitis. And again, this is getting an immune complex deposition, which for whatever reason is irritating medium-sized blood vessels. But typically on the elbows and knees, we don't quite know why. Maybe because they get banged a lot and that trauma triggers them to appear more than elsewhere in the bottom. We don't know. But when we see rashes on the knees and elbows, we dermatologists, we get very, very excited because there's a tremendous workup with these patients, including undiagnosed HIV, autoimmune disease, including lupus. Sometimes internal malignancies can trigger this as well, or a larger vessel vasculitis can have this as a secondary effect. We get very excited when we see this. And this has been described in COVID-19 as well. So you don't have to learn this one, but if you just want to remember something that rash on knees and elbows, think outside the box a little bit, and that might trigger COVID as well. So in fact, here it is. These are patients with rashes on their knees and elbows. This is, the rash is called erythema elevatum diutinum. It's a long name. You don't need that, but on the knees and elbows, pink bumps on the knees and elbows, pink bumps on the knees and elbows. And when we say knees and elbows, we often mean hands as well. Hold on a second. No. ¿Cómo? Sí. I apologize for that. That's the problem with doing this from my office. They will always interrupt me correctly to take care of patients. But again, although this is a knees and elbow disease, we dermatologists are taught to look at the hands, just like in the disease hand, foot, mouth disease, which is caused by, we also are trained to look hand, foot, mouth, and buttocks. So even though it's called hand, foot, mouth disease, we also look at the buttocks. So this as well. And finally, my colleague, and I don't see your name there, I apologize, who asked the question as to whether or not these spots with pernio, chilblains, are raised or not raised. And
yes, I'm David. I'm from Uganda, Kabale.
Oh, I hope we can continue our conversation. We have a dermatology program. We're really trying to help. There are actually 2 of them, one in Kampala and one in Mbarara, where we have a good presence with American dermatologists who do a lot of teaching in a very formal manner, partnered with Harvard Medical School and University of California, San Francisco. So perhaps we can continue conversation about how we can help.
No problem. You can continue after the presentation.
Thank you. But with these are petechiae. These can be found in patients. But again, if you're having petechiae, it probably means something is wrong with your platelets, and not necessarily COVID, but it's been seen in these patients as well. So these are just bonuses right here. And this is bonuses as well. This is just some more findings of that as well. So again, unusual rash in a patient that you don't have a good answer for. The theme of showing you all these extra ones right here is just think COVID, okay? So 3 main rashes plus a few bonuses. So this is really it. This is what you've learned today, okay? There are 5 main groups of rashes. Number 3, I asked you to learn today, the pseudochilblains and pernio. I asked you to learn the 2 papulosquamous eruptions, which are pityriasis rosea, that's the Christmas tree rash, and the morbilliform eruption, also known as the maculopapular drug rash. That's what can be caused by penicillin, but can also be caused by COVID. And then when you weren't looking, I snuck in 2 other rashes that you already know. You all know urticaria. You're pros on that. You're all pro on vesicular rashes. You think about chickenpox or other things like that, shingles, but also think about COVID-19. And then livido is the big bad one, big purple limbs, purple toes. That's really a very serious threatening blood clot issue in the larger blood vessels. And that's been reported a lot with COVID toes and people losing limbs in COVID early on. It's not very common, okay? So it is well. So back to my patient right here. Again, part of her workup, you can see that when I saw her in the hospital, mucosal rash on the lips, not really reported for COVID so much, but a little bit. Petechiae, yes, reported for COVID. Elbow rashes, remember we love elbow rashes in dermatology, good for COVID. This is chilblains right here on her. It's instead of being purple red, it's actually white, it's blanched out. That's her chilblains right there, good for COVID. Again, on her toes, she's got a little purple on her heels. That's the chilblains type rash on her heels, very good for COVID. And that was what prompted me to press her to get tested for that. And thanks to this now study, we do know that these findings are predictive in these patients. This is a busy slide. Please don't read it, as I should have made it shorter. But this was a beautiful study by the British Association of Dermatologists, whereby they asked asymptomatic people, 330,000 users, over 6 weeks to just do daily reporting of whether or not they have a fever or any other signs or symptoms of COVID-19 disease, and whether or not they had tested, and if their test result was positive. And then they retrospectively looked to see if there was anything that preceded that. And indeed, in these patients, 20% of patients, of those patients who tested positive for COVID-19 that were reported, 21% of them, the only thing they had previously reported was a rash. So it does matter very much as well. And again, 17% of patients who end up having other symptoms with COVID will describe a rash coming on first. And in 20% of patients with no other signs of COVID-19 disease, they will only have a rash. And you now know these 3 rashes very well. And so quite frankly, if you just ask the patients, although there are 5 main categories, remember 3 of those you learned today, 2 were just a review, urticaria and vesiculars, okay? Just ask them, do you have a rash somewhere on your body? Well, yes, I do. And then did a rash kind of recently appear? You don't want to hear about somebody who's telling you about their psoriasis they've had for 5 years. That's not COVID, okay? But yes, it just appeared and it's raised, it's on my trunk, it's on my body, or it's on the hands and the feet. And those 2 things can help get you the question they should be referred for COVID testing. So again, my patient back from a year ago, should she be tested? Absolutely, she had hives. And with that, I'd like to thank you all very much for the presentation today.
I have a question for you.
Yes.
Wouldn't it be easier to learn the rashes that are not associated with COVID?
I often have on my bookshelf back here some of our textbooks of dermatology, but oh my gosh. It's really, if you do, the high yield are these 3. It's these 3 rashes right here. Because that's what most people are showing up with. They're showing up with the rash you already know, the maculopapular rash, the otherwise called the morbilliform eruption. You know that. They're showing up with urticaria. You know that. They're showing up with vesicular eruptions, very unusual, but you know how to look out for them. And they're showing up with these chilblains on the fingers and toes. And also with the one, again, all of us in the Northern Hemisphere, when we practice spring and fall, we all see these patients seasonally who show up with a Christmas tree eruption. So the purpose is to trigger thinking about COVID. But a longstanding reaction a patient who comes to your office because they've had psoriasis for 6 months, really that's not COVID.
Could you tell us, give us an example of a rash that shows up acutely that you wouldn't think of COVID?
Well, like a cellulitis type of appearance. So like a cellulitis type of appearance. Okay. That would probably be one. Or something which would be really good for an external insult. Here in Florida, I'm close to the beach, so we get people who get jellyfish stings, and they get sea bathers eruption. Sea bathers eruption are caused by little teeny tiny jellyfish larvae that get trapped inside your clothing as you're swimming. And you don't feel it usually until 12 hours or 24 hours later, and you have a rash if you're wearing a shirt like I do on the whole trunk. Because they've gotten under there and they stayed trapped there. When you walk out of the ocean and rinse off, all their little buddies go away, but the ones under your shirt stay trapped there, so you get a rash on the trunk. So those might be something you don't need to think about so much.
Thank you.
I have a comment or a question. I guess it's a comment. This is Mark Berenson again. I guess what Dr. Falk was getting at is it seems like a lot of rashes could be presentation of COVID. I mean, the reality is these rashes have been happening forever, long before COVID. It's just, usually a viral syndrome will cause any assortment of these rashes. But COVID just happens to be the recent most popular, very densely presented virus this past year. So, I mean, it could be any viral syndrome. It just happens to be COVID. It happened a lot recently.
Excellent.
Is that accurate?
That is absolutely accurate. In that in the past, when we get our spring fall eruptions, people get these rashes, we treat them with a little bit of topical steroid, tell them not to worry about it, because it's probably just an otherwise innocuous upper respiratory infection that's not causing any problems. However, if you're practicing and you're concerned about the public health aspect of COVID and coronavirus, meaning somebody's living at home and they're taking care of their wife who might be on chemotherapy and might be very susceptible to COVID, and they come in with this kind of rash. In the past, we might have said, well, it's okay. It's not a big deal. You probably just have a little bit of adenovirus. Don't worry about it. It's going to go away. But that same patient now might possibly have been exposed to COVID, and it might be prudent to consider testing that patient, particular if you're concerned about more transmission in the household or to other people.
Thank you for that. That was an excellent talk, by the way. I really enjoy it, every bit of it. Thanks.
Thank you.
I underline that excellence and talk. John, what textbook would you recommend that if we're going to buy one that we could have as a resource?
Well, probably let's see. We in dermatology use a book by an author named Habif, Habif. He's actually a private practice doctor in America who I think is retired. And that's the textbook we usually give medical students who are interested in dermatology. It's very concise. It's also pretty complete, and it raises some questions. So I like Habif for people who are in maybe general practice, not dermatologists. It's a really good way to start. As we continue more conversations with Global Grand Rounds about integrating more dermatology, my colleagues who again are in faculty practices at University of Pennsylvania, at Harvard Medical School, and University of California, San Francisco, who have ongoing dermatology global health formal programs supported by the NIH, who have been training dermatology residents in Botswana and in Tanzania through the Regional Dermatology Training Program, can probably help to identify specific resources which would be really helpful for people in those areas. And that might also be not cost prohibitive, like buying a big American textbook.
Could you speak on chilblains affecting the nose or the ears? I mean, do you see that in the hospital setting? Is this something that's more in colder climates? I mean, how does that, cold areas?
It's a great question. So so whenever you have inflammation of small vessels, the blood flow is going to slow down in those small vessels. And if you have vasoconstriction because you're in a cold area, or you're just exposed to the cold, it's going to show up more in those blood vessels. That's why it typically shows up in the fingers and the toes. Those are the coldest parts of the body. the big study that was done in Spain, and it was done in Spain when everybody was sick in the hospital back in March of 2020. My wife is from Spain, and I spent a lot of time in Spain. Spain can be hot as heck in March. Northern Spain can also be very cold in March. So I don't have an answer to that, but you're right. The other cold parts of your body, like the nose and the ears, have not been so much described with COVID rashes. The American Academy of Dermatology is building up a database of more COVID eruptions and more COVID rashes. So I'll ask my colleagues about that. That's a great question.
Thank you. One other thing is pseudo chilblains versus chilblain. I mean, I got hung up on that. Sorry, if you could describe that.
If you say somebody has chilblains, usually that labels them as having the same thing, otherwise known as lupus pernio, meaning they have lupus, and they need a workup. Oops. Are we still there?
Sure.
Okay. Right.
Very
yeah.
good.
So if somebody has chilblains, usually that is the assumption is their underlying cause of those findings is lupus.
Okay.
And so we refer to it as pseudo chilblains when it's not lupus associated, but that's kind of a wishy-washy term.
But it's the same process for both.
Yes, it's inflammation of the blood vessels secondary to either the autoimmune mess that is lupus or the autoimmune mess that is having a viral infection in your body.
Very good. Thank you.
Well, these are just excellent grand rounds, John. We're going to have you back. Hopefully, we might actually have regular dermatology once every month, every other month. It's so instructive for us to have that. I want to just take this moment to thank the contributors to the Together in Telemedicine. We gave a fundraiser this past Saturday. We raised about $50,000 towards establishing. That'll be upwards of each site may run $10,000. That'll be 5 new hospitals setting up with complete equipment. They can partake in grand rounds. They can do consultations. They'll have really the ability to do telemedicine and interact with us. I want to particularly thank Larry Falk for his contribution, and Keita Mehta, and Dr. Gary Barth. They were very, very generous. So thank you all, everybody, and our time is up. And remember, beginning in June, we switch over from Good being the medical director to Mike Katsaris and to Greg Pescia, who will be the co-directors in terms of these rounds and really the efforts of Global Offsite Care to spread telemedicine to improve world health. It's been a real great run. Thanks, everybody. Adios.
Thanks,
Bye-bye.
Dr. Good. Dr. Strasswimmer, will you stay on for just a second? I think Dr. Agu over there had a question. Dr. Agu, do you want to ask your question? Maybe unmute and ask your question.
Yes, this was a very interesting lecture, and I'm a plastic surgeon consultant working in Saudi Arabia, and it was really very interesting. But one thing that I noticed in the presentation is that almost all the rashes, almost all the skin lesions were mentioned. So I just want to, which means every skin eruption, every skin lesion can be a sign of COVID. So I just want to ask the presenter, is there any rash or any skin lesion that you will find and you say 100% correct that this is not COVID?
Yes. So thank you very much for your question, and I understand you're practicing in Saudi Arabia now. And I'm so happy to have you joining us here. A new skin rash, which you could probably comfortably say is not COVID, would be one for which you have either a presentation which doesn't make sense, and I'll explain those in a moment, or something which you have a very good story. So here in Florida, we get a lot of people who come with rashes which have an explanation. I was out gardening, and maybe they got into some weeds which had a little bit of poison ivy or poison sumac, something like that. Or I was out gardening and maybe they had, like I had the other day, I actually had acute urticaria because when I was jogging, probably a little caterpillar fell inside my shirt, and caterpillars, their little spiny parts in the caterpillars trigger urticaria right where they stick you. And then that urticaria actually, in my case caused urticaria on the rest of my chest, but it disappeared everything the next day. So it was a good explanation for that. Or as I had previously mentioned, sometimes people are swimming in the oceans here. We get sea bathers eruption, which is a rash that comes out. So if they say, well, I was swimming yesterday, now I have this rash, something that makes a good sense. The second category would include those skin rashes that just don't make sense for COVID. For example, cellulitis, something that looks like cellulitis, or something that looks like, maybe a deeper type of infection, maybe a more slowing moving type of infection. But I guess what would be safe to think about is if you look at a patient and it might trigger you to wonder whether it was due to a new medication, that might also prompt you to think whether or not this could be due to COVID. It doesn't mean everybody has COVID, but as we now hopefully move into a phase whereby we're getting it more under control with vaccinations and better public health campaigns, it's still going to be very important to make sure people are screened and identified so that we can keep people properly tested and quarantined to slow down the future spread. So that's not the answer you're looking for. I know that it would be nice if I could say clearly, characteristic rash A, B, and C, you could forget about COVID, but the more we learn about COVID, including the case I presented, which has never been described today before, with that autoimmune phenomenon whereby her bone marrow macrophages are consuming the red blood cells and the platelets, that's never been described. We found that 2 months ago. So I think as we see more COVID, probably as a function of the massive number of people who are being exposed to COVID, that's why we're seeing such a crazy variety in the number of rashes, much like we did, 100 years ago with syphilis.
Okay, thank you.
Thank you.
Thank you, everybody. And I did want to ask Dr. Smith quickly if you have the butterfly with you. If you don't, it's no problem. We can show it next week. But if you do, maybe do you want to show it briefly, really quickly, or up to you, Dr. Smith?
No.
There you go.
Yes, we do.
You have it. Okay, great. Maybe we'll show it next week too, because I think a few people have left already, but it would be lovely if we could see it today.
Yes, give us a minute.
Sure. Take your time.
Alexa, when we finish this call, could we continue maybe conversation a little bit about the next step to incorporate more of my dermatology colleagues in this session?
I would love to do that.
Okay.
Those who listen to COVID-19 lecture, excellent. And we're using now this, or perhaps distribute the ultrasound device that Dr. Smith has as one of our best new diagnostic approaches. Dr. Smith.
Yes, we do have it, but we forgot the gel again.
It's okay. We're a bit past our time. How about next week you give us a brief rundown on the butterfly IQ, how it's been helpful for you, how you use it and whatnot. Does that sound like a plan?
Yes, it does. It's
Okay.
been very helpful documenting.
Great.
It's done a few on screen so far.
Great.
Got to see that image next week. That'll be great.
Yes, we will build in time next week at Grand Rounds. Thank you, Dr. Strasswimmer. Thank you, everybody, for coming.
Okay.
Look forward to seeing you next week.
And
Bye-bye.
then Alexa, Dr. Strasswimmer wants to talk a little bit about.
Everything else besides the gel.
Go ahead, Fahim.
I just want to confirm that to incorporate more dermatologists. Was that what I heard correctly?
Yes.
Yes.
Okay, great.
So I guess I did send that invitation, Dr. Strasswimmer, to, I'm going to stop the recording actually.